I am now pleased to introduce our first speaker, Dr. Cara James, Director of the Office of Minority Health at the Centers for Medicare and Medicaid Services and co-chair of the CMS Rural Health Council. Dr. James is a nationally recognized thought leader and expert on health disparities, health equity, and improving outcomes for vulnerable populations. In her current role, she leads CMS's efforts to meet the unique needs of minority and underserved populations. She previously served as the director of the Disparities Policy Project and the director of the Barbara Jordan Health Policy Scholars Program at the Kaiser Family Foundation, where she was responsible for addressing a range of healthcare issues, including disparities in access to care among individuals living in health professional shortage areas. We're so grateful that Dr. James is with us today to provide an overview of federal strategies to address rural health disparities. Dr. James?
Thank you so much, Catherine, and good day to all of you. I'm really pleased to be part of the forum that we're having today and want to thank NIHCM for providing the opportunity to discuss these important issues. And as Catherine mentioned, I'm going to talk today about what we have underway at the federal level. One, I just want to say that there is a lot of activity that is happening at the Department of Health and Human Services around rural health. I'm going to focus primarily on what's happening at the Centers for Medicare and Medicaid Services, but I want you to know that we are working very closely and collaboratively with our colleagues at the Federal Office of Rural Health Policy, CDC, NIHCM, and others to improve health care in rural America. So as we start off, one of the things that we have been really focused on at CMS is rethinking rural health. And that is one of our priority initiatives of the administrator that began with our release of our first CMS Rural Health Strategy that we launched last year. And the strategy was developed using stakeholder feedback. We did listening sessions across the country in rural communities such as Pocatello, Idaho, and Rifle, Colorado. But we also talked to rural Americans and beneficiaries to find out what matters to them and what they wanted us to focus on. We then led to the development of 5 objectives that you see here that really focus on trying to apply a rural lens to CMS programs and policies. So thinking about the impact that our policies will have before they're developed rather than waiting at the end to see once they're implemented. Second, we're focused on improving access to care through provider engagement and support, helping our rural providers to be able to meet the needs and provide high-quality care to beneficiaries. Third is advancing telehealth and telemedicine. As you can see, the fourth one is to empower patients in rural communities to make decisions about their health care. And finally, we know that this is not work that we can do alone, so we're working to leverage our partnerships to achieve the goals of the CMS Rural Health Strategy. And that includes those collaborations that are both within the federal family, but also outside, working with states and other community groups to help improve access. In terms of applying that rural lens, one of the things we start with is, many of you are aware, we produce a lot of rules and regulations. We don't do sort of grant programs the way some of our other sister agencies do, but we talk about through our rules how we are addressing our programs and making changes to them. And I highlight this because one of the things as an ask to each of you is to really think about and to provide us with that feedback. We try to get things right. We don't always get things right, but we need your help to improve upon what we are suggesting. So through our rules, we always do a notice of proposed rulemaking where we can get those comments and to feed back into that loop to make sure that what we are putting out really will be helpful to rural communities. We also have, through a number of our programs, we have our quality payment program, and we are so pleased that through our technical assistance, we had a number of rural providers, over 90% of eligible rural clinicians who participated. And while they had a choice of not having to report for the full year, as you can see, more than half of them did in a number of areas, including quality improvement activities, and nearly half who reported for a full year in promoting interoperability. And as you can see, 93% of our rural providers received a positive payment adjustment, and more than half of them received an additional adjustment for exceptional service. I think really noting the high quality care that we see in rural communities by our rural providers, and little difference between those of rural providers in terms of a median score compared to those in larger practice areas. In the space of telehealth, we've made a number of advances. We continue to try and push the boundaries to improve access to telehealth services. So just a little over a week ago, as we finalized our rules for the upcoming year, we added additional codes to telehealth through Medicare to help in terms of a bundle of episode of care for the treatment of opioid use disorders. So these 3 codes start with an initial visit and then provide follow-up as well as additional time associated to help improve access to services through telehealth. We also have added additional services in virtual communication to try and address some of the challenges that we have seen around the ability to do store and forward or remote evaluation, as well as to access services via telehealth outside of a clinical setting. So these virtual check-ins are one of the ways in which we have been able to address that, and we finalized those last year, as well as adding additional prolonged preventive care service rules to the list. In the space of trying to improve competitiveness of some of the hospitals and workforce, we finalized in the summer our hospital wage index, and this is one way to try and level some of the playing field across geographic regions for low-wage hospitals and high-wage hospitals, including many of those that are rural. So we have increased the wage index for those hospitals in the value below the 25th percentile, so that they will have increased by half of that distance to try and close that gap to help support that. We also, in the space of trying to improve workforce and make care more easier for our providers and reducing that burden, we've finalized some changes just in the past week and a half to our direct supervision changes. So this has been a space where we have deprioritized previously the audit of the direct supervision, but we have now finalized a change where we are changing that minimum required level of supervision from direct supervision to general supervision. So we've heard the feedback, and that change is now going into effect. We also provided greater flexibility for physician's assistants so that absent of state rules, that their current supervision requirement to clarify that physician supervision is a process in which a physician assistant has a working relationship with one or more physicians to supervise the delivery of care. So these are some of the ways in which we're trying to help improve access and workforce, addressing some of those needs in rural communities. We also have a big focus on addressing the opioid epidemic and substance use. And so the CMS Opioid Strategy is a 3-pronged approach that includes a focus on prevention, treatment, and data. And we've already, as a result of the SUPPORT Act, implemented a number of provisions, including covering services provided by opioid treatment programs, as well as permitting prescription drug plan sponsors to suspend payments if there's a credible allegation of fraud, and a number of other provisions. And again, in some of the work that we just finalized within the last week and a half, we've added a new Medicare benefit for opioid use disorder treatment. So beginning January 1, we include these services as defined by the FDA-provided opioid agonist and antagonist treatment medications. And one of the things that we want to highlight is that, as you can see for the beneficiaries, there is zero copayment for them in 2020, really trying to reduce some of that financial burden, and also noting that the 2-way interactive audio-video communication technology can also be used to try and, again, reach some of those beneficiaries in rural areas. In another couple of areas, just in our innovation, we have a number of innovative models within our Center for Medicare and Medicaid Innovation. So our maternal opioid misuse mom, focusing on neonatal abstinence, as well as our integrated care for kids model, and looking at the integration of behavioral health and physical health, and the new emergency triage, treat, and transport, trying to link in EMS services and helping to treat individuals where they are, as well as our primary cares initiative. And then we encourage everyone to stay tuned as we have another model that is underway that is focused in rural areas that really will help be a collaborative effort of providers, purchasers, and payers to allow them the flexibility to address the specific needs of their communities. And one of the other areas, we held a forum earlier this year and had participants of one of our colleagues on the phone and a colleague of hers in focusing on how we can improve access to maternal health care in rural communities. So as you can see, between 2004 and 2014, a number of rural counties have experienced closures or loss of their hospital obstetric services. We also have seen a number of hospital closures. So this has been an area of focus that we had starting with that forum and building on that. This is another area where there's a lot of attention in maternal health services being provided at the department level as well, and collaborations that are happening across the agency to address some of those challenges related to maternal morbidity and mortality, and it greatly aligns and works well with the focus as well on rural. So in my last couple of minutes, the other area that I wanted to talk about is that intersection of rurality and health disparities, specifically focused on some of those disparities by race and ethnicity. So in collaboration with the CDC, Office of Minority Health and Health Equity, we've done some analysis of looking at racial disparities among individuals within rural areas, and just in a couple of highlights, we note there are disparities. This shows you the gap in fair poor health, but we also see disparities by geographic distribution. So we know that where you live matters, and as you can see, whereas about half of rural Americans live in the South, for rural African Americans it's 94%, and nearly 60% for Hispanic Americans. For our American Indian and Alaska Native in rural communities, 38% of them are located in the West, where overall it's only about 11% of rural adults. So we know that that matters in terms of services and expansion of access to insurance and other programs. We have as well, looking at that income distribution, we heard earlier, as Catherine mentioned, that in general, rural Americans tend to be poorer than urban Americans, and you can see that within those rural Americans there are some disparities where we have significantly higher rates of African Americans, American Indians, Alaska Natives, and Hispanics who are living on less than $25,000. So we have a tool if you want to play and look at the data at the local level. We have our Mapping Medicare Disparities tool, which allows you to drill down to the county level, and you can see which counties are, the striped counties represent those that are urban counties, and so the solids are ones that are rural counties, can compare a number of conditions. And lastly, we also are focused on work around the social determinants of health. We know that much of what is happening to our health is a result of things outside of the clinical setting. There are a number of frameworks that are being used to talk about the social determinants of health. This is one from Healthy People 2020, but we don't have very good data being collected, and definitely not in a standardized way. So one of the things that we have been working on is how to improve some of that collection and support that. And in our post-acute care rules that we put out earlier this year and finalized just a couple weeks ago with the home health rule, we have begun through our patient assessment to incorporate some collection of social determinants data through those assessments. So that will be rolling out shortly. So that is a whirlwind tour. There is a ton of stuff I was not able to talk about. Hopefully we can get to it in some of the questions, but I just wanted to give you a sample to know that there is a lot of effort and activity that's happening in rural health at the department and across CMS in particular. And if you want more information or have questions, please visit our website or contact us at ruralhealth@cms.hhs.gov. And again, I want to thank Catherine and NIHCM for providing the opportunity to share some of what we're doing, and look forward to the other presentations. Thank you.